Oops. Oh, thank you, Emily. I am first going to, it's my great pleasure to introduce Professor Rebecca Wong. And Professor Wong is a radiation oncologist in Princess Margaret Cancer Centre in Toronto. She is an old fellowship mentor, master's mentor of mine, and then a colleague. She completed her medical training in Sheffield University in the UK, and her oncology residency in Queen's University, and a master's in clinical epidemiology at McMaster's University. She's the principal investigator for the Ontario radionuclide therapy trial for neuroendocrine tumours, and the oncology lead for theranostics at the University Health Network in Toronto, Canada. She's also chair of the Canadian Theranostics Leaders Summit Planning Committee 2024. So her research and clinical interests are very much in the areas of theranostics, patients living with metastatic cancer and gastrointestinal malignancies. And she's been a lead investigator for multiple clinical trials, evidence-based guidelines in the past and current. So I will hand you over to Professor Wong. Many thanks again.
Thank you so much for having me. I visited Ireland a few years ago, and it's great to be here with you, bring back wonderful memories, and my wonderful memories with working with Aisling as well. So I was charged with talking about neuroendocrine tumors and radiotheranostics. Here are my disclosures. Theranostics describe a rapidly growing field through the use of designer drugs. It's designed to recognize a molecular target or targets using suitably selected ligand, its payload, a radioisotope. By switching the radioisotope, a short-lived energy emitting for diagnosis and a longer living and high energy for therapy, this construct gives the potential of it being a magic bullet, biologically targeting cancer cells while sparing normal tissues. It is projected by 2026, it will be over $12 billion sector globally, with therapeutics leading the growth. It is a modality that shares many parallels with external beam radiotherapy. It is expected to be the next pillar in cancer care alongside external beam radiotherapy, chemotherapy, and surgery. It also demands tremendous collaboration across disciplines. The map on the right demonstrates the wide gap in access between North America and Europe, which has the most access and is most developed, whilst broad sectors of the global population currently have difficulty access or have no access. The evolution of theranostics over time has been slow until recently. At the top right, I like to show a little bit of history. Is a popular article featuring the famous patient who was cured of thyroid malignancy using iodine-146, iodine-131 back in 1946. It took over 10 years before radioactive iodine as a single radioisotope was approved for clinical use. Since then, we see the somatostatin receptors being described, PSA receptors being described, and from the discovery of these molecular targets to actually a drug being approved for imaging and for treatment, it's about 20 years or so. But I think we're getting faster for some of the reasons that hopefully you share in driving the excitement. So over the next 20 minutes, we'll review some of the current evidence, some special considerations in using radiotheranostics, especially in neuroendocrine patients, and a few thoughts on emerging opportunities. In neuroendocrine tumor, over time, several systemic options have been tested and approved for standard use. First came the somatostatin analogs in the form of octreotide, subsequently lanreotide. And then there's chemotherapy, temozolomide being described, and then the classical form being used in neuroendocrine is Captem. And then targeted therapies in the form of sunitinib and everolimus. And then there's lutetium-177 dotatate, which is the current standard of care after many versions of different isotopes being tested. The reason why we recommend PRT to patients can be summarized in this one slide, documenting the outcomes in the high-quality randomized trial called NETTER-1. Specifically, at 20 months, the proportion of patients who are managed with standard of care, which here is high-dose octreotide, the progression-free survival was 11 months, compared with 65 months in the arm receiving PRT. Similarly, patient outcomes have improved. Time to decline of quality of life in the control arm was 7 months, and in the study arm was 29 months. Whilst the overall survival was not statistically improved, with a median of 36 and 48, it can be seen that in early years, there's a separation of the curves favoring PRT, but they emerge in the longer-term follow-up. It is also noteworthy that because neuroendocrine tumor is a slowly growing tumor, the response rate is not high, as documented by RECIST, and it's in the order of about 18%. The second reason why PRT is so attractive, and before it's available in Canada, patients travel to Europe to try and get this or do without, is because of its favorable toxicity profile. Only 9% of patients had a serious adverse event that's related to treatment, and 5% of patients, the treatment was discontinued because of adverse events. Taking a closer look at the toxicity profile, grade 3 to 4 toxicity is documented in about 41% of patients, compared with 33% in the control arm. The most common side effect is nausea and vomiting, now when we use this rate is much lower and is attributable to the amino acids that are being used to protect the kidneys, and when lysine and arginine, the pure form of the amino acid solutions, are being used, the nausea and vomit rates significantly reduce. Then the other side effects are hematological, with grade 3 to 4 lymphopenia occurring about 9% of patients, and in general terms, hematological toxicities occurring in less than 10% of patients. Other experiences from our patients: headache occurring about 16%, and alopecia in about 11%. Usually, it's just thinning of the hair, which is noticed by our patients as a dominant symptom in some cases. Dose reduction occurred in about 7% of patients, and 77% of patients who successfully completed all 4 cycles. With this well-conducted study, FDA approved lutetium-177 for the treatment of neuroendocrine patients in 2018, and shortly after, the same happened in Canada. And I see that a health service executive in Ireland also approved it around this time, and for very similar indication as is marketed for GEP-NETs who have progressive disease expressing somatostatin receptor positivity. In Ontario, the price tag for the drug is about $35,000, which is about 24,000 euros per cycle. And that's an important feature that is driving a lot of the discoveries and development, but also impairing as a barrier for access for us to solve. NETTER-1 is really opened the door for the use of radionuclide therapy in the modern era. Even though this is in a very rare cancer, and the next to come will be prostate cancer, which we'll be hearing more about from Dr. Higgins. The next major development in neuroendocrine tumor is NETTER-2. And the key aim of the study is to look at lutetium dotatate as first-line therapy in patients with higher grade tumors, with Ki-67 of 20 to 50%. And it's worth noting that there's actually no other randomized trials in systemic therapies that targets especially the grade 3 population. This slide summarizes the study design as a 2-to-1 randomization. There's a possibility of crossover, which makes overall survival a difficult metric to judge this treatment strategy. It's powered to detect a doubling of the median progression-free survival, increasing it from 15 months in the control arm to the expected 30 months in the study arm. Similar to NETO-1, the control arm received a high-dose octreotide, and the study arm received a standard dose of octreotide simultaneously as lutetium-177 dotatate. The study was positive. It successfully reached its primary endpoint with a progression-free survival of 23 months versus 8.5 months in the control arm. It also showed a high response rate of 43% compared to 18% in NETO-1 group. And I think that reflects the fact that patients with somewhat more active disease, higher grade disease is being targeted, and the higher response rate we anticipate with the same drug. There's also a very favorable adverse event profile with greater than grade 3 toxicities, 15%. There is also a planned subgroup analysis looking at 7 different factors. I want to highlight, especially for physicians who are thinking about how to use this drug, the significance of different grades and different primaries. And the message here really is that across all of these subgroup analyses, the effect of the treatment is essentially the same in whichever subgroup you look at. So specifically in patients who have grade 2 and grade 3, the benefit is the same, about equivalent in magnitude. And similarly for pancreas, small bowel, the magnitude of benefit and expressed in the hazard ratio is about the same. So should patients with grade 3 neuroendocrine tumor be treated with Lutathera as first-line therapy? That's probably the most hotly debated question, both in conferences and in publications. I just showed you that the study reaches primary endpoint, and it's the only randomized trial that demonstrate its effect compared with standard of care use of octreotide with a hazard ratio of 0.28. Where the uncertainty lies is in relation to its late toxicities, in particular myelodysplastic syndrome and effect on the kidneys, which we'll talk a little bit more in a moment. And the optimal sequencing against current standard of care choices. Somatostatin receptors is progression-free survival the most important reason to drive treatment decision? Maybe for patients with more aggressive disease, rapidly growing symptomatic patients, it is very important. But for the grade 2 slower growing, maybe the sequencing can be different, extending the treatment options available. So the answer to these questions remains to be defined. My interpretation is that this treatment is, as has been documented, is superior to high-dose somatostatin if progression-free survival is the goal of therapy. And it should be available as a treatment option as first-line treatment for grade 2 to 3 neuroendocrine GEP-NET patients. So a few comments on clinical consideration beyond clinical trials when using peptide receptor radionuclide therapy. First one is toxicity. If you are working in this field and trying to develop a new drug, the 2 most important complication and need for dosimetry to assess normal tissue doses is the kidney and the bone marrow. The normal tissue doses for the kidney is modeled after external beam radiotherapy, widely quoted using a 23 gray as the dose limit. However, it's well known that this is a much less slow dose rate tumor treatment, and therefore that 23 gray probably is a really conservative, and higher doses can be delivered, although the data needs to be accumulated for us to have a different metric to use. In the NETA trial, Dr. Strasberg and the colleagues actually separately reported the late effects on the kidney, and demonstrated in the panel on the right is essentially the GFR is really quite constant in subsequent follow-up. And that aligns with many of the experts who are working in this field, that if you have normal kidney function going in, the real threat to renal function is quite low, especially with the use of amino acid and hydration as pre-medication, which is standard of practice. Investigators have also looked at what about in patients with borderline renal function. And I can quote you this one retrospective study that looked at a group of patients who have stage 3 chronic renal insufficiency. And basically what they were able to model and demonstrate is that on average in these higher risk patients, the eGFR drops about 2.5% per year. And dosimetry, individualized dosimetry, is therefore strongly recommended for these patients. So a word on individualized dosimetry. If you look at the product monograph for Lutathera and Pluvicto, there's no requirement for individualized dosimetry. And what that is very similar to external beam radiotherapy. We use computer software and regions of interest to document how much radiation dose is being absorbed by the normal tissues. You can use the same method or similar methods to document the dose that is being delivered to the tumor, and use it to guide your thinking and future developments as well. The image here is just to explain how it's being done after the drug is being delivered. SPECT scans are obtained at various time intervals. The more time points, the more accurate it is, and the methods have evolved so that you can actually do one time point, but we frequently do 2 time points at 4 hours and 72 hours in our practice. And you can use these time point measurements, which is activity that is captured on your SPECT scan, and plot a curve of how it's decaying from the body, from normal tissues. And the area under the curve basically would give you the dose that is being absorbed. Moving on. The second most important complication is therapy-related myelodysplastic syndrome. In external beam radiotherapy, we recognize that patients could develop second malignancies. And for adults, we typically will quote a 2% lifetime risk occurring by 5, 10, 15, beyond years after being exposed to radiotherapy. It was a bit of a shock for me when I started treating these patients in seeing therapy-related myelodysplastic syndrome, which is MDS, myelodysplastic syndrome, as well as acute myeloid leukemia. And I've seen patients very shortly after completion of delivery, which is much earlier than what I would expect with external beam. Here is a systematic review that document the risk, and basically in this systematic review, it concluded that the probability of developing treatment-related myelodysplastic syndrome, neoplasm, is about 2.6%, with a range of about 2 to 5%, and the time point of developing is about 35 months, with a range of 4 to 125 months, as reported in the literature. And this is not new in systemic therapy, contrasting with breast cancer with 0.5% versus some other cancers requiring a lot more systemic therapy, ranging from 1 to 4%. So this complication for patients who have life-threatening disease that's immediate life-threatening may not be a serious consideration. But for patients who are otherwise going to live with the disease for many years, especially with younger patients, this is a significant concern that we need to think about. This is an area that I'm very interested in, and we actually now know that myelodysplastic syndrome actually can be predicted looking at clonal hematopoiesis. Patients who subsequently develop this complication probably already have some of the clonal hematopoietic changes, and receiving the PRT is the last trigger that resulted in the expression of this complication. And there are now genetic signatures that could help identify this type of patients dating back 20 years from the time of developing these type of myelodysplastic changes. So we would really like to be able to identify these patients early, and this is just a trial that we have embarked upon looking at this. The third thing that is important to think about when using this treatment is in patients with mesenteric disease. And that's not uncommon with small bowel neuroendocrine tumor, and is well documented from clinical observations that these patients will can develop small bowel obstruction, and the PRT can be associated with development of small bowel obstruction. Whether it is that the time is already close, that the patient was destined to do that, or is it the PRT, we don't really know. But now there's a strong some recommendations to use dexamethasone as a strategy to dampen the inflammatory response, which may improve the probability of developing this. There are also molecular signatures that can use to identify patients who are likely to benefit from this treatment, and it's coming into the market. So in addition to knowing that this works, there are lots of clinical parameters that will help us identify the right patient to treat with PRT. And there are many strategies going forward in optimizing this modality, including using different isotopes to increase the therapeutic ratio, and understanding the dose absorbed and how it might change our thinking, etc. So I just want to highlight the study Action 1, which precisely asked the question of using a hotly debated excited in the use of actinium-225, which is an alpha emitter. So the another one trial that we've been talking about uses lutetium-177, which is a beta emitter. And the important difference is that an alpha emitter causes double-strand breaks and penetrates much less into the normal tissues, and therefore can result in much higher cell kill and potentially less toxicities. And this trial is designed to look at retreatment for patients who have failed lutetium-177 in grade 1 to 2 well-differentiated neuroendocrine patients, comparing 4 cycles of actinium-225 dotatate versus standard of care chemotherapy. It's ongoing right now, and hopefully in a couple of years, we'll have some results to share. There are Lutathera orphans. And because and this term is being used to describe all the other patients who have somatostatin receptor overexpression, but is not being studied in these large randomized trials. In Ontario, we conducted a tumor-agnostic PRT study and recruited about 20% of non-GEP-NET patients. And we're not the only one that shows that it can be effective, but this prospective study also demonstrates comparable outcomes in patients who have non-GEP-NET when treated with PRT. Finally, just a word about why radiotheranostics is so exciting. Its design and the mechanism of action fits perfectly with the concept of personalized medicine, identifying patients and treating them through the molecular targets, increasing specificity and reducing toxicity. It capitalizes on the advanced molecular imaging techniques that is emerging and coming into clinical practice, is the ability to non-invasively understand the heterogeneity of the cancers within patients and between patients, and the large number of biomarkers, molecular markers that become potential markets for us to innovate and build new strategies. Finally, the medical community is now able, as demonstrated by these randomized trials that have been done and is coming into armamentarium, that can translate into understanding how that will work and bring it into practice. This is just the beginning. Beyond use of single radiopharmaceutical in a one-size-fits-all strategy, there are many different ways that we can improve the therapeutic ratio. We can bring it earlier into the treatment trajectory, including potentially in identifying patients that we want to prevent cancers, localized administrations, combining it with different radioisotopes to improve the therapeutic ratio, targeting the microenvironment. And in fact, there's emerging data to use this modality beyond cancer in CNS mental illness, for example. So my take-home message is that lutetium dotatate is the first designer radiopharmaceutical in solid tumors. And we know how to do these trials and is now brought into clinical practice. Together with Pluvicto for metastatic prostate cancer, theranostics and its mechanism of action is positioned to become the next key modality in cancer care. It does remind us that proactive planning is necessary to ensure we're ready to meet the patient care need and ready to engage in the innovation opportunities that is to come. Thank you for your attention.
Thank you so much, Dr. Wong, for that. That's an excellent presentation. We are going to move on to Dr. Higgins, and then we're going to do questions afterwards. I have a couple of questions myself, so look forward to hearing more. So our next speaker is Dr. Martin Higgins, and he is a consultant radiation oncologist at Cork University Hospital. He graduated from medical school at Trinity College Dublin with honours degree, and he completed his radiation oncology training here in Ireland, followed by fellowship training in melanoma, skin cancer, cutaneous lymphoma, and brain tumours at Peter MacCallum Cancer Centre in Melbourne, Australia, where he gained extensive experience in managing all of these cancers with techniques, different types of techniques. So we're delighted for his presentation today. Martin, I can't see you, so I'm going to turn on your, oh yeah, there you are again. No, you're fine.
My slides okay?
Yeah, we can see your slides perfectly.
Great,
So
thanks
we'll take it away. Thank you.
Aisling. So when I was asked to give this talk, the suggested title was GU Indications for Radioligand Therapy, and the email came out and said, make sure that my talk had the same title. But I suppose really it's it's radioligand therapy for prostate cancer is where the bulk of the evidence and the practices at the moment, which I'll mostly talk about today. My disclosures there. And I suppose I'll really talk about, in this time frame I have, the current indications and evidence for the licensing of PSMA target therapy for prostate cancer in Europe and in Ireland. I suppose Professor Wong has given an introduction to theranostics, so therapeutic and diagnostic uses of radioisotopes. And the this is using specifically the prostate-specific membrane antigen as molecular target for imaging and then therapy in prostate cancer. It's a transmembrane carboxypeptidase. It's highly expressed in prostate cancer, including metastatic lesions up to 1,000 times more than in normal prostate cells. And it's upregulated with ARPI therapy. So you'll hear in novel antiandrogens, androgen receptor targeted agents, androgen receptor pathway inhibitors, they're all the same. So there's numerous different acronyms, but the use of ARPIs or ARTAs increase PSMA expression. It's relatively restricted in normal expression, so it's expressed in prostate and prostate metastases and in salivary and lacrimal gland tissue, which contributes to its toxicity, which we'll talk about, and also the kidneys. It's an excellent target for PET imaging and an excellent target for radioligand therapy. There are multiple radioisotopes and ligands in use and in trials. The main one we will talk about today, where the evidence is 177 lutetium PSMA 617, which is marketed as Pluvicto, and is the most commercially available. But there are numerous other isotopes, including copper, and then which are either beta emitters and then alpha emitters, as Professor Wong has touched on. So actinium-225 and thorium-227 and astatine-211. So 177 lutetium PSMA is targeted at the same sites as those identified on PSMA targeted PET imaging. So needs to say patients need a PSMA PET scan. There's good evidence from Europe, from kind of advanced nuclear medicine services, which is Spain, France, Italy, and Germany, that only 11 to 33% of patients eligible for a PSMA scan will ever really have one. So patients need a PSMA scan to identify them for PSMA targeted therapy. But this lutetium PSMA therapeutic agent is targeted to PSMA positive cells, same size we see on a PSMA targeted scan. So they need a PET scan to identify patients. It delivers a high absorbed dose to the tumor, which correlates with tumor uptake. And then there's some evidence that the mean whole body tumor uptake and the SUV mean of the tumors impacts activity and effectiveness. A higher uptake of lutetium of gallium PSMA PET associated with a trend towards greater PSA response. So just a slide to show this is kind of 20 or even 15 years ago, the therapeutic landscape for metastatic prostate cancer, for hormone sensitive, castrate resistant, castrate sensitive, was all just ADT really. It's progressed dramatically then in the last 5-10 years for patients with hormone sensitive disease early on, then castrate resistant metastatic, first with the advent of docetaxel as per the Charter study for high volume disease, and then the addition of novel antiandrogens, abiraterone, darolutamide, apalutamide, and the use of second line taxanes, PARP inhibitors, and then of course radioisotopes such as radium-223 and radioligand therapies such as lutetium PSMA. So it is really later on in the course of treatment. It's third line treatment is what where lutetium PSMA is licensed and currently used mostly after chemotherapy and a novel anti-androgen or androgen receptor targeted agent for more castrate resistant advanced metastatic disease. This is just a slide showing again the stages of localized hormone sensitive metastatic and castrate resistant metastatic, and some of the trials that have guided the evidence for the treatments we give at the moment. What I'll talk about first and mostly today is the current licensed indications of second line or later targeted therapy for castrate resistant prostate cancer. So trials include, I'll discuss new PSMA therapy and vision in the current indication. So in terms of licensing by the European Medicines Agency, which covers the licensing of in Ireland, it's licensed as Pluvicto, which is the brand name of the drug available, and lutetium PSMA 177 is licensed in combination with androgen deprivation therapy with or without an androgen receptor pathway inhibitor or androgen receptor targeted agent for treatment of adult patients with progressive PSMA positive on scan metastatic castrate-resistant prostate cancer who've been treated with an AR pathway inhibitor and taxane-based chemotherapy. So third line metastatic or last line treatment really, and including those with visceral metastatic disease not suitable for radium-223. It's received generic justification from HIQA, the Irish Health Information Quality Authority, which assessed the data and felt that it is reasonable to make it available for suitable patients. And then it's been assessed by the National Center for Pharmacoeconomics which make advisements to the government and the HSE about reimbursing medications. And as of the 12th of August 2024, it's advised that it not be reimbursed by the state for patients in Ireland to have. So currently it's only available for self-pay for patients at a cost of about €18,000 per cycle. So just to bring us back to where we're at the moment, then the use of it in metastatic castration-resistant prostate cancer for post-taxane chemotherapy and androgen receptor target agent. And this is just to show the NCCN North American guidelines. And on the right lower part of the screen there and highlighted is for progression prior on docetaxel, a novel hormonal therapy can be used. So in terms of eligibility for PSMA, and a lot of this is based on the inclusion criteria from major trials, which we'll come on to discuss, but on imaging, they must have a recent PSMA PET scan. It should really be within the previous 6 weeks. They must have metastases with uptake above the liver, so an SUV max of about 2 to 6, but that might not choose the patients that are most suitable for treatment. They should have CT measurable lesions that have the uptake above the liver and no urinary obstruction because it's excreted via the kidneys and it can worsen urinary function. In terms of lab function, they should have adequate renal function with eGFR at least above 30 mils per minute and good bone marrow function because it is marrow suppressive or myelotoxic. Also, patients who have in their history shouldn't have severe dry mouth or eyes, as those are significant side effects of lutetium PSMA therapy, and can follow radiation protection restrictions. This is just to look at the selection criteria based on scans, and this is from the first phase 1/2 trial of lutetium PSMA, which was published in 2018 in The Lancet by Michael Hoffman, his group in Peter McCallum in Melbourne. But basically, patients should have PSMA avid disease and ideally not have a lot of PSMA non-avid disease or FDG PET avid non-PSMA avid disease, where they'll have active disease that won't take up PSMA and have a significant therapeutic effect. So this just from that lutetium PSMA, small phase 1 into phase 2 study, first published evidence for lutetium PSMA, a small number of patients and showing significant PSMA response. This led on then to the therapy trial, which was the first randomized evidence for lutetium PSMA in humans. And this was to determine the activity and safety of lutetium PSMA versus cabazitaxel. So the eligibility here was castrate-resistant disease post-docetaxel chemotherapy in patients suitable for next-line cabazitaxel, progressive disease with a rising PSA, adequate renal and hematological function, good performance status, and also they had to have very avid disease on PSMA PET scans without discordant avid FDG disease that would make them unsuitable. Based on these criteria, about 28% of patients were unsuitable for inclusion on the trials that were screened with a PSMA and PET scan. Its primary endpoint was for PSA more than 50% response, and 66% of patients with lutetium PSMA versus 37% of the patients with cabazitaxel had a PSMA response of more than 50% reduction. So it's 29% absolute greater than cabazitaxel. And its progression-free survival, while it wasn't powered to show that, it was a secondary endpoint. It was superior with a hazard ratio of 0.63. Also, a secondary further analysis by Bateau et al. In 2022 showed that those with an SUV mean, so a higher mean uptake in SUV or higher PET avidity disease, had a better PSA response, shown the waterfall plots with cabazitaxel on the left, the lutetium PSMA on the right, and you can see on the right lower, those with the more avid disease had a better PSA response. So in summary, the therapy then was the first randomized evidence of phase 2 trial, which showed a PSA reduction of more than 50% in 66% of patients with lutetium PSMA. It essentially showed about a 4% improvement, 4-month improvement in progression-free survival with no significant increased toxicity versus cabazitaxel. Just in terms of the groups were well distributed between the lutetium PSMA and the cabazitaxel arms. And interestingly, 90% of patients had bone metastases, but only 7% of people had visceral metastases in the lutetium PSMA arm. So often, obviously, we discuss this as those patients that are post all other lines of treatment with visceral disease not suitable for radium, but a small portion of people had visceral disease on this trial. And we could see that it was very well tolerated, although there was greater dry mouth and dry eye on the lutetium PSMA arm in terms of hematological toxicity, fatigue, vomiting, GI side effects. It was equivalent to or superior to cabazitaxel. So the first major phase 3 trial then published in 2021 was the VISION trial published in the New England Journal of Medicine. This was a very large randomized phase 3 North American trial for patients who were castrate resistant, progressed on at least one AR inhibitor and 1 to 2 taxane-based chemo regimens. It was 830 patients with a good life expectancy, PSMA positive disease. These patients just had to have PSMA uptake greater than liver on the PET scan. And it was versus best standard of care. The best standard of care here excluded chemotherapy and radium-223, so it would have been ADT. And the endpoint was overall survival and radiological progression-free survival. So just, I stated it was people with good performance status, PSMA avid disease on a PET scan, and progressed to at least one androgen receptor targeted agent and at least one chemotherapy with adequate organ function. Just to say that the best standard of care was planned before randomization. It could not include investigational agents, chemotherapy, or radioisotopes. And then the best standard of care could include pain medications, transfusions, hormonal therapy, and receptor pathway inhibitors, and external beam radiotherapy. 87% of patients scanned, so had a PET scan and met the pre-specified criteria, and they were allocated to treatment or the control arm. So again, the median imaging-based progression-free survival was 8.7 versus 3.7 months, and the median overall survival was statistically significantly improved at 15.3 months versus 11.3 months, so about 4 months survival, with a hazard ratio for death of 0.62. Again, 90% of the patients had bone disease, not bone-only disease, but only about 10% of patients had visceral disease. So a lot of patients had bone or nodal disease, so not very advanced visceral metastatic disease. And again, to show the median overall survival was improved by about 4 months to statistically significantly to 15 from 11 months. For the overall survival, it was improved more or less amongst all subsets of patients. Those where the confidence interval crosses 1 is for the presence of liver metastasis, which was a small proportion of people. It was 48 patients out of 400, so less than 10%. And then those African American or Asian, which were a small portion of patients as well, so not well represented. The radiologic progression-free survival was much improved as well by about 5 months. And again, across all subgroups, apart from those that weren't well represented, such as African Americans and Asians. Post lutetium PSMA, there was a smaller amount of external beam radiotherapy and chemotherapy. And also toxicity, again, standard of care here, which wasn't chemotherapy. There was more bone marrow suppression and dry mouth and renal side effects. But as previously seen, when compared to chemotherapy, it's very well tolerated with a similar outcome. So the conclusions from the authors of the study were that it was safe to combinable standard of care with castrate-resistant metastatic prostate cancer and was well tolerated. And it favored as a treatment option in these patients. So just to compare vision and therapy, obviously vision was phase 3 and much larger. It was in addition to standard of care rather than instead of it. The imaging threshold, so the uptake required on a PET scan was much lower, so they had less avid disease. And only 30, so less patients failed the screening for vision than on therapy. Also to note, and you'll see in a lot of the evidence I'll present, the dose is different. So our current licensed dose is 7.4 gigabecquerels times 6 cycles, 6 weekly. But a lot of different trials have different dosing, frequency, and dose. The response rate was more in therapy, but the progression-free survival, overall survival here are very similar when compared to after chemotherapy, as opposed to versus chemotherapy. A significant portion, over a third of patients, can have a PSA rise after the first cycle of lutetium PSMA. And this can persist at cycle 2. But the first cycle PSA rise doesn't predict poor outcome. But at 12 weeks after 2 cycles of lutetium PSMA, if you look at the yellow curve, those that have an increase after 6 weeks, compared to the most extreme, the purple curve at the top, more than 90% decline, you can see that the outcome is much better in those that have a better response after cycle 2. So those that have more than a 90% decline, their overall survival median wasn't reached, compared to less than 10 months in those with a PSA rise after 2 cycles. This really suggests, as a smaller study from Australia, showing that if you have a SPECT CT and PSMA, which shows progressive disease after 2 cycles, it's probably not proceeding with the 6 cycles of lutetium PSMA. There's a debate Dr. Wong referred to in terms of dosimetry. Dosimetry isn't mandated and it wasn't done routinely on the trial, on the VISION trial. But patients receiving, there was some evidence from a small trial study by John Violet and Peter Mack in 2019 suggested patients receiving less than 10 gray were unlikely to receive a fall PSA of at least 50%. But there was a trial from Germany then that showed that, dosimetry maybe didn't necessarily relate to outcome. But really, some patients might have very low uptake and get a lower dose, where they may require not to have treatment at all or have an escalated dose. And some patients may get a very good dose and have very PSMA-avid disease, but we might not know. There was an ad hoc analysis then of Vision post its publication as well, which basically showed that those with a higher PSMA uptake and higher ICV mean had a better outcome to disease. Although not unexpectedly, patients with a higher amount of PSMA-avid disease or higher disease burden did worse overall. So just to show here that those with a SUV mean of more than 10 seem to have better progression-free survival and overall survival. So what we don't know from Vision really is the optimum patient selection criteria, the optimum dose and schedule, the impact of dosimetry, whether it's necessary or not, if retreatment or progression can make a clinical difference, is standard of care plus lutetium PSMA better than lutetium PSMA alone, what synergistic therapies can be combined, or what benefit there might be earlier in the disease course, such as in chemo-naive patients, people post-chemo who are pre-ARTA, hormone-sensitive prostate cancer, so earlier disease or localized disease. Just to show a phase 1 dose escalation trial showed that 54% of patients in this trial were actually treated to 22 gigabecquerels over 2 weeks, so 11.2, 11.1 gray gigabecquerels per cycle, and without significant dose-limiting toxicity with good outcomes. So, higher dose, shorter number of treatments might be optimum in the longer term. And this is showing a similar cohort of patients with castrate-resistant metastatic prostate cancer, post-chemotherapy and ARTA, adding in a PARP inhibitor showed excellent PSA response, better than those others. So that is where our current guideline and evidence comes from in terms of castrate-resistant metastatic prostate cancer. And it is kind of last line treatment as currently licensed in Europe and in Ireland. I suppose, in the future, it should come earlier on as first line, metastatic castrate-resistant prostate cancer. Prior to chemotherapy, we have many patients who aren't fit for chemotherapy, aren't fit for docetaxel or clazetaxel, who may benefit from it instead. I don't have much time left, but I'll just mention very quickly, it can be used slightly earlier than in castrate-resistant metastatic prostate cancer in chemo-naive patients, which is the PSMA-4 trial, which were those with progressive castrate-resistant disease. There was a change in ARTA treatment, so from ABI to ENSA or vice versa, or adding lutetium PSMA. And it showed a progression-free survival improvement to 11.6 months from under 6 months. This trial wasn't powered to show an overall survival advantage, and most patients, so 78% of patients actually crossed over from ARPI change to lutetium PSMA at progression. So the overall survival is the same because all patients essentially almost got the treatment at progression. But it did, show an improvement in progression-free survival. So these are chemo-naive patients of, almost double the progression-free survival, maintain quality of life is better on the FACT-P score, and delay in worsening of bone pain, but without an overall survival seen. And similar, another trial published at ESMO in Barcelona this year, showing a similar patient cohort of those that were chemo-naive, progressive metastatic castrate-resistant prostate cancer, had an improved progression-free survival of 9.5 months versus 6 months, and better biochemical failure-free survival, more than 50% PSA response, but 85% of patients crossed over from the observation or the alternate ARPI arm to lutetium arm, so a survival event wasn't possible. And there are multiple other trials in chemo-naive patients, those prior to enzalutamide, showing progression-free survival, and also earlier on in hormone-sensitive metastatic prostate cancer. But that might be a talk for another day.
Thank you so much, Martin. That was excellent. Thank you so much, Dr. Higgins. So I might move on to some questions and answers. Does anybody have anything they want to pop in the chat? While you're thinking, I might start then. So Dr. Wong, one of the things that we're trying to figure out here is in terms of the practicalities of developing a theranostics program. and who's involved and who runs or leads and all that kind of stuff. And I know that there's varying ways of doing it. And I'm just wondering from your experience, what has been the best way? Obviously, your way is the best way, but what do you think, having looked at many of the different ways of doing it, what seems to work well?
I think this modality is will only be successful with significant cross-discipline collaboration. Of course, the use of radioisotopes sits in the nuclear medicine department historically and traditionally, and the delivery of it is still very much relying on the nuclear medicine technologists to do so. As oncologists, of course, bring the knowledge about how to look after these patients, both in the short term and the long term, and perhaps have more insight into where the opportunities. And medical oncologists, surgical oncologists will have different expertise to bring to the conversation. At our center, we are very insistent on it being a joint leadership between nuclear medicine and radiation oncology. I think bringing the understanding of radiation dose, radiobiology, I think have the potential of accelerating the field. So ideally, having one oversight party that is jointly led by oncology and nuclear medicine, I think will be the best way of moving forward.
Okay, thank you. One of the points that you both came up or discussed was about personalized dosimetry, and I struggle with this a little bit as well in liver when we use Y90 is oftentimes people may believe that the higher doses the better. That doesn't necessarily translate to better outcomes. So I'm just wondering, when you talk about personalized dosing, especially from a neuroendocrine perspective, how is it that you've been able to look at this, and where do you think we can move forward? And I'll ask Martin the same question as well from a prostate perspective.
I think, as Martin pointed out, there's currently no high-level evidence that the dose should drive a change in practice. However, the way I see it is that dose has to be an important factor. We know that from external beam radiotherapy. And I don't believe that it will be the be all and end all, but unless you measure it, you will never know. It's like not collecting your hemoglobin or your ECOG status. It has to be an important feature. I think the tricky part is the resources that is required to get it done. So I think at this point in time, it takes personnel and leadership that has the vision as to what the future will hold to support this activity.
Martin, do you have any thoughts on in personalized dosimetry, especially from a prostate perspective?
No, I agree, because some patients will get a very high dose from the standard treatment, and some will get a low dose. And the dose that's used in the different prostate cancer trials, it's different from trial to trial. Frequency, the Stampede 2 trial, which we would hope to open in Ireland, is giving I think 7.2 gigabecquerels 1 week apart times 3 cycles. And then there are dose escalation studies showing a lot higher doses are safe, but maybe some higher doses are needed for some patients. I guess something like prostate cancer, where it's going to be very high volume with a large number of patients, maybe personalized dosimetry mightn't be available as standard. But and also in my experience working in Australia, where you had nuclear medicine physicians that are therapeutic and diagnostic, which we don't necessarily have in Ireland. Whereas they would, see the patient, cancel the patient, deliver treatment, but also do the dosimetry, review the PET scans, review the dose, and they would have the time allotted to it. So I agree with Rebecca as well, the resources needed. And maybe, depending on the type of treatment or non-standard treatment as well, such as newer indications or orphan tumors, or giving very high doses, or non-responders, or patients needing retreatment, we might focus dosimetry on those patients, maybe while the resources are limited, But we should have, in a country as small as Ireland, a unified approach using, the same dosimetry technology in the three kind of major public centers and networks, and kind of collaborate on it.
Yeah, I agree. And do we have any data on cost effectiveness at all for either of the current indications? And I'm assuming that that's one of the reasons why it hasn't gotten through in Ireland. Or is there any other ways that we can advocate for things like Pluvicto? I don't know, from a cost effectiveness position for lutetium, Rebecca, if there's anything that you're aware of.
Yeah, it's interesting if you look at the Lancet Commission on Radiotherapy and Radiotheranostics, it actually took a very similar approach to assessing the social impact of radiotheranostics, including Lutathera and Pluvicto. And if you, so that's one view, and showing the savings in terms of society. I think each of the countries have done their own cost-effectiveness analysis and have arrived at the current pricing. It is not cost-effective, and I think the debate is ongoing. In Ontario, I think because the improvement in progression-free survival and overall survival is the magnitude is modest for Pluvicto, I expect that with and the number of patients is so large, but I expect with some of these newer trials that demonstrate effectiveness in earlier stage disease would motivate the change. In Ontario, I'm pleased that the province is taking a more broader view in terms of its impact on society and is consider funding it. So the conversation is ongoing.
Yeah, because it's interesting that across Europe there's very different points of view in terms of, in Belgium and Germany and France, even in similar economies to Ireland, it is funded and found to be cost effective. And obviously, I suppose in the United States, then it can be more so insurer based. And in Australia, they never really reimbursed radium-223, even though it's much cheaper, and they reimbursed lutetium PSMA is why it kind of took off to be publicly available to large numbers of patients. But as well, I suppose, the toxicity and the time and cost and patient management of patients having capacital second-line taxanes is quite significant. So I suppose it depends on what cohort of patients you want to look at. And a lot of these patients are having no other treatment, are going sooner, and it might be 4 to 6 months sooner to palliative care and death, which is significant for those patients who have no other lines of therapy or aren't suitable for chemotherapy. So even if it was restricted to certain patient cohorts in terms of those that aren't suitable for chemotherapy, as certain other chemotherapy regimens are, that there's a place for it.
Thank you both. That was really excellent. I just think there's such a huge world out there for theranostics and such a space for it. And, especially in Ireland, it's an open space for us to be collaborative on. So, Dr. Wong, thank you so much for coming today. And I know it's early in the morning in Toronto, so really appreciate you getting up and joining us. And Dr. Higgins, thank you so much for joining us during your lunchtime. I just want to remind you that the next seminar series is January 13th, 2025. The speaker is Bruce Levine of University of Pennsylvania, titled From Innovation to Translation to Patients, the Future of Genetically Engineered T Cells. It's starting at 12 noon as opposed to 1 p.m. when we normally would start. So once again, Dr. Wong, Dr. Higgins, thank you so much for sharing your experience of theranostics. Thanks, everybody.
Thank you.
Thank you for having me.
Thank
Bye.
you.